This week we're going to be talking about neonatal hypoglycemia. I will try and make it very short and very practical, and we will be alternating between two cases. The first case, you are called in labor ward for a 3 kg term baby who was born by a 26-year-old primigravida with no comorbidities. The sister in labor ward is worried that the HGT is 2 millimoles per liter. Otherwise, the baby is well. And the second case is a 1.8 kg 38-weeker baby who is born from a 34-year-old with also no comorbidities, and the HGT is 1.9 millimoles per liter. The sister is just saying the baby is a bit jittery, and other than that, the baby appears well. So those are the two cases we'll be discussing around this week. Welcome to PaedsCrib, where we guide young minds to heal young lives through case-based discussions. I am Dr. Manyesane, a pediatrician based in East London. If you find value in our content, don't forget to subscribe, like, and share with peers. And make sure you hit the bell notification so you never miss an update. Let's dive in and grow together. So the first thing that you would want to make sure that you do when you receive such neonates is to first define neonatal hypoglycemia. There's actually no uniform definition for neonatal hypoglycemia, and existing guidelines, they differ significantly. But most studies have actually discovered that to maintain normal neural function, the HGT of a neonate has to be kept at least at or above 2.6 millimoles per liter. So that is why most guidelines use that 2.6 as a definition of hypoglycemia, that if you have an HGT of 2.6 or below, you must consider that this neonate might be hypoglycemic, because studies have discovered that at that level there's already brain damage to the neonates because of this hypoglycemia. The other thing we have to take into consideration is the Whipple's triad. The Whipple's triad talks about the level, number 1, and 2, there has to be symptoms associated with that level, and 3, there has to be resolution of symptoms once you give this neonate a glucose-containing solution or feed. That is the Whipple's triad. It has been found that the Whipple's triad is not actually sensitive in neonates, but it really helps you into trying to figure out if this is a symptomatic hypoglycemia or asymptomatic hypoglycemia, because this will help you in actually managing this patient. So in my unit, I still consider the use of the Whipple's triad, because it helps us into the management of these neonates to know that, are you asymptomatic level or are you not asymptomatic level, and therefore the way we're going to go about it managing each patient depends on that. The other thing you have to consider when you're dealing with a neonate with a possible neonatal hypoglycemia based on the level is what is called a physiological hypoglycemia, that it is a physiological phenomenon for an HGT to drop in neonates after birth. This is because they were getting the glucose supply through the placenta from the mother, and now because the baby has been separated from the placenta, so there is no continuous glucose provision that this neonate now is getting, and therefore HGTs are expected to drop. In a normal term infant, these HGTs have been found to drop to as low as around 1.4 millimoles per liter to 1.9 millimoles per liter. That is in the first hour of birth, and they have been seen that they increase gradually around 2 hours to around 2.3 millimoles per liter, and this is even before intervention. So this neonate hasn't been fed or done anything, but the levels, they start to increase on their own. This is usually due to the postnatal adaptation of the metabolic pathways of the neonate, because they start, especially if this is a term neonate with no comorbidities or risk factors of having hypoglycemia, so they start adapting by the metabolic or endocrine pathways like gluconeogenesis and lipolysis with the release of fatty acids and ketones, and that HGT slowly, gradually starts to increase on its own before you even start intervening. And this adaptation has been found to be important in actually minimizing the risk of this neonate having recurrent hypoglycemias, because sometimes we intervene very fast when we get a low level, and we tend to inhibit this normal adaptation in this term neonate that is supposed to happen. So that is something that we still need to keep into consideration, that there's a physiological phenomenon that is supposed to happen in this term neonate, where the HGT can drop as far as 1.4 millimoles per liter, and it will start to increase gradually around 2 hours, and around 3 hours it's even more than 2.3 millimoles per liter. And therefore the definition by the level of hypoglycemia in a healthy neonate with no risk factors of hypoglycemia depends on the timing at which the HGT was done. So it has been found out, if that HGT has been done in less than 3 hours, where you are expecting the HGT to be way above, if it was done around 3 hours, where you are expecting the HGT to be way above 2.3, and you find out that at 3 hours the HGT is still less than 2, like it's around 1.9 millimoles per liter. So that becomes significant for that neonate, because you are expecting that this neonate must have adapted to this level, and therefore you were not expecting to find a level that is less than 2.3 around 3 hours. It's supposed to be higher than that, and therefore a level of less than 2 or 1.9 millimoles per liter around 3 hours of life in a term neonate with no risk factors for hypoglycemia, it becomes very significant. And also a definition of a level of less than 2.2 above 3 hours to 24 hours of life, it's still considered as very significant in a term neonate with no risk factors. And then a level of less than 2.6, which is the one that we're using, it's usually start being used more than 24 hours of life in a neonate. So if you have a neonate who's more than 1 day of life and is having a level that is equal to or less than 2.6, you take that as significant. If you have a neonate who is between 3 hours to 24 hours of life who's having an HGT that is less than 2, you take that as significant. So that's very important to keep these definitions according to the age of the neonate and according to whether this neonate has got a risk factor of hypoglycemia or not. Is it an infant of a diabetic mother? Is it a growth restricted neonate? So those are the kind of risk factors. Is it a preterm baby? Those are the kind of risk factors you look for and take into consideration with the level that you are given. Now, the next thing that you would want to make sure you do after you have defined hypoglycemia and you have taken into consideration physiological hypoglycemia is to look for possible risk factors that this neonate might be having that would make him at risk of having hypoglycemia, and also look at symptoms of hypoglycemia. Now, looking at these two things will actually help you in the management of this neonate going forward on how to go about managing this neonate. Some of the risk factors I've mentioned already, like infant of a diabetic mother, these neonates are born with hyperinsulinemia. That makes them at risk of having persistent hypoglycemias. If you have a preterm neonate with decreased glycogen stores and absence of brown fat, and therefore these preterm neonates will be prone to having hypoglycemias because they can't adapt by the endocrine or metabolic pathways because things are immature. Or if you have a child with small for gestational age, like your IUGR babies or small for gestational age babies, these babies have found to have a transient hyperinsulinemia because they're coming from a stressful environment, and on top of that they also lacking brown fat because they are wasted, and they also have depleted glycogen stores because they have started using their glycogen inside the uterus to survive into the stressful environment that they are coming from, and therefore they will have risk factors for hypoglycemia. So those are some of the risk factors. Or if you have a baby who is large for gestational age and therefore tends to consume the glucose more rapidly than a normal weight. So those are some of the risk factors of hypoglycemia that you must look out for. And the symptoms First, the change in the level of consciousness. They might be lethargic or irritable or stuporous, even in coma. They might have seizures, they might be jittery, they might have tremors, they may have temperature instabilities, they might have tachycardias or bradycardias, they may have apneas. So those are some of the symptoms of neonatal hypoglycemia. And jitteriness is actually common in our neonates. As a presentation of neonatal hypoglycemia. So you have to know what you look for in trying to find out if this neonate is actually symptomatic at this level, because that is going to help you in managing the patient going forward. How drastically are you going to go about managing the patient? Now, if you go back to our two patients that you were called for in labor ward with low levels of HTT, the first baby being a healthy 3 kg baby with no risk factors for hypoglycemia, but has got a level of 2.2. which is less than 2.6, and therefore the sisters are worried. So this is a kind of a neonate where you would think about physiological hypoglycemia. You would think that this neonate, depending on how old the neonate, this neonate may actually start to adapt to this level on his or her own. And also the way you're going to manage this patient is also asymptomatic. So you take that into consideration. You are a healthy term baby that I'm expecting you physiologically to start adapting to this level. And secondly, you do not have any symptoms of hypoglycemia. The sisters have actually mentioned that the baby looks otherwise well. So those are two important things to keep in this neonate for you to know how you're going to go about managing this neonate. Whereas the other one, it is a 38-weeker, meaning that this is a term baby, but is small for gestational age because the birth weight is 1.8 kgs. So it means now already you have a neonate who has a risk factor as being small for gestational age of hypoglycemia, because as I've said, they have a transient hyperinsulinemia, they have decreased glycogen stores, and on top of that they are wasted and therefore lacking the brown fat. So this neonate is actually prone of having hypoglycemia. And on top of that, the sisters have actually mentioned that this baby is a bit jittery. So there is also a symptom of hypoglycemia. So the way you're going to go about managing this particular neonate is definitely going to be different on how you're going to go about managing that normal, healthy 3 kg term baby. Now let's look at the metabolic or endocrine response to the physiological response to hypoglycemia. Looking at the endocrine and metabolic pathways. So the first thing that happens when you are hypoglycemic or a neonate is hypoglycemic, it will be inhibition of insulin, because you don't need insulin because it will further lower your blood glucose. So insulin gets inhibited, and there will be then stimulation of the 4 counter-regulatory hormones to insulin. What are those hormones? It is glucagon, it is epinephrine, it is cortisol, and it is growth hormone. Now, when you're looking at these 4 hormones, the first 2, glucagon and epinephrine, they tend to be released in the acute stages of hypoglycemia, whereas cortisol and growth hormone, they tend to be a delayed response. They get released later. These 4 hormones, they then stimulate 3 pathways, and these pathways, they will end up causing the formation of energy in a state where a patient is hypoglycemic. Let's take glucagon. So when glucagon is released, it will facilitate the process of glycogenolysis, which is breakdown of glycogen in the liver, glycogen stores in the liver to release glucose. So in a form of providing this neonate with a glucose. And then when epinephrine gets released from your sympathoadrenal response, this epinephrine will facilitate lipolysis. So fat breakdown with the release of fatty acids and ketones. These will also help in providing this neonate with some form of energy. Then later on, cortisol and glucagon, they will start kicking in. These 2 hormones, they facilitate gluconeogenesis, which is the process of forming or providing energy using non-carbohydrate substances like amino acids and fatty acids. So that is what happens at the metabolic level or endocrine level in a patient with hypoglycemia. The four counter-regulatory hormone to insulin, they get stimulated, and these hormones, they facilitate the three pathways that will help this neonate produce some form of energy. So this becomes important, especially when you're gonna manage a patient with persistent hypoglycemia, where you're gonna start needing to using drugs. You need to be able to decide who to give glucagon and who to give cortisol. For example, if you have a preterm neonate with persistent hypoglycemia for some reason, it will not make sense for you when you have to treat this preterm neonate pharmacologically to give glucagon, because you know this preterm neonate doesn't have enough glycogen stores. So there's nothing for glucagon to work into. There's no glycogen stores to break because this is a preterm neonate. And therefore, this will then tell you that you need to use some other form of pharmacological management in this patient, like cortisol. And if it's a term baby with persistent hypoglycemia, then glucagon will work because a term baby is supposed to have enough glycogen stores for glucagon to break. So that's why it's important to remember these pathways in a state of hypoglycemia in a neonate. So management of neonatal hypoglycemia depends on whether you are dealing with a symptomatic hypoglycemia or you are dealing with an asymptomatic hypoglycemia. So that's the first thing that you have to figure out. If the child is asymptomatic and it's a healthy neonate with no risk factor for hypoglycemia, just like the first case, the 3 kg healthy baby with no risk factors of hypoglycemia with just a low level. So you look at the level. If the level is just less than 2.6, but it is more than 1.5, what you do is you feed the baby at normal maintenance. So a normal maintenance for day 1 term neonate will be 60 ml per kg per day. So you start feeding that baby, and then you repeat the HGT in 30 minutes. And if your HGT is still less than 2.6, this is where you are allowed to increase your total intake a day ahead. So instead now of keeping this baby on 60 ml per kg per day, you can actually increase the total intake to 90 ml per kg per day. Now, while you are doing this, you calculate the glucose delivery that you were giving at 60 ml per kg per day. And if for a term healthy neonate, it has to be between 4 to 6 milligrams per kg per minute. If you were delivering that, then you can safely just increase your total intake to 90. So before you make any adjustments to the fluids, increasing the total intake, you have to actually find out, was I actually delivering enough glucose before with what I was giving? So the normal, as I've said, it's 4 to 6 milligrams per kg per minute. In patients that have risk factors, this glucose delivery can be actually increased to 8 to 10 milligrams per kg per minute. Okay, so once you increase the total intake to 90 and you have calculated your glucose delivery and you try to maximize it to 10 milligrams per kg per minute, you continue to repeat the HGT after every 30 minutes up until you get an HGT that is more than 2.6. If after 30 minutes of increasing to 90, your HGT is still less than 2.6, this is where we add things like Polycos, high dextrose solution into your feeds, or you can, if you don't have Polycos, you can add 1 ml of 50% dextrose in a 30 ml of milk, just to concentrate the dextrose in the milk, and you repeat the HGT again after 30 minutes. And if it's persistently low, it means this is a child who will need to be admitted in the neonatal unit and might need to be investigated as to why is the hypoglycemia persistent. Okay, if the level is between 1 to 1.5. This is where you start your total intake a day ahead already. You start it around 90 mils per kg per day, and you repeat your HGT after 30 minutes, and if it's still low, after 30 minutes, you calculate your glucose delivery and you will adjust your fluids accordingly, according to how much you were delivering. And if it's still persistently low after 30 minutes, this is where you can also add polyglucose or 1 ml or 50% dextrose per 30 ml of milk. If it's still persistently low, you will admit the child to the neonatal unit, because also this is a child who will need to be investigated and possible started on drugs. Okay, so that is how you manage an asymptomatic child. You just feed the baby and do 30-minute HGT checks up until your HGT is more than 2.6 millimoles per liter. The lower the level, the higher the feeds you're gonna start the child with. Okay, then if this is a symptomatic child, this is where you start with a neolite bolus or a 10% dextrose bolus of 2 mils per kg. So in this patient, you want to increase the glucose as quickly as possible. But what is important now for this symptomatic patient, after you have bolused the baby, please do make sure that you start the patient on a maintenance immediately. Maintenance can be fluids. If feeding is contraindicated, let's say this is a child with severe signs of hypoglycemia, is hypotonic, is lethargic, is having seizures, so you might be unable to feed the child. So you give a bolus and then you maintain the child with a neolite infusion. Or if there's no contraindication to feeding, you give a bolus and you feed. Now, most people, the mistake that they do, our young doctors, they will give a bolus and then they will not start these neonates on a maintenance, and therefore the HGT remains low. So it's important to take note that you only give a neolite or a 10% dextrose saline bolus for symptomatic neonates. We don't really like neolite boluses because every time you're giving a bolus, you're causing a surge of hyperglycemia, and that hyperglycemia can stimulate insulin, and this child now will be hyperinsulinemic. Now, if this bolus has called hyperinsulinemia, now you're running a risk of having a neonate with persistent hypoglycemias because of the insulin that you have stimulated. So you need to keep in mind that every time you are bolusing for hypoglycemia, you are causing that hyperglycemic surge, which will stimulate insulin. And insulin takes time to decrease in the circulation. It takes about 4 hours for it to actually go down. So this child will be in a hyperinsulinemic state for 4 hours after you have given the neolite bolus. And now if you don't maintain after that bolus, it means you're going to have a child who runs a risk of having persistent hypoglycemias. Now, same with the asymptomatic, you do your HGTs after every 30 minutes. And make sure you calculate your glucose deliveries in between, making sure that you are giving between 4 to 6 or to a maximum of 10 milligrams per kg per minute. Now, the minute you have reached a maximum glucose delivery and the neonate still remains hypoglycemic, this is where now we think about investigating this neonate. Why is this hypoglycemia persistent? And we start introducing the drugs. Okay, so what is important when you're going to introduce the drugs is that you take a look at the type of a neonate you are having. If this is a term baby and a neonate with enough glycogen stores, this is where you can start giving a glucagon IV stat dose initially, and then if that stat dose after 15 to 30 minutes your HGT hasn't responded the way you wanted it to, you can even go as starting glucagon infusion. But now if this is a preterm neonate, a child who doesn't have glycogen stores, it will not make sense to start with glucagon in a preterm neonate because there will not be any glycogen for the glucagon to convert. So this is where in preterm neonates you can start with cortisol. So those are the two drugs that we usually use. There are other drugs like octreotide, which is a known antihypertensive, but it has been found to also cause insulin resistance or inhibit insulin. So it can be used in such cases. But please do make sure that you first optimize the glucose delivery before you can start your patient on the drugs. Okay. So in investigating these neonates, the first thing that you want to make sure you do if they have a persistent hypoglycemia, which is a level of less than 2.6, even while on maximum glucose delivery, you take your bloods, you confirm your glucose first, you send your blood, your serum glucose to the lab to confirm that it is actually low. And we take what we call a critical sample. A critical sample, it will be that glucose level. You would want to make sure you do your blood gas. So in these patients, on top of looking at the metabolic pathway disorders, we also look at things like the other causes like inborn errors of metabolism. So you make sure you do your blood gas, make sure the child doesn't have metabolic acidosis with a high lactate. Then you do your hormones, make sure you do your insulin level to see if this is not a child with a hyperinsulinemia, hence the persistent hypoglycemias. You do your counter-regulatory hormones. The one that we measure is usually your cortisol and your growth hormone. And then you also want to make sure you send your beta hydroxybutyrate, which is one of the ketones, because as we've said, during the process there will be lipolysis with a breakdown of fatty acids and ketones. So you send those labs. You can even do ammonia, and other workup for inborn errors of metabolism. But the main thing is that you confirm that the child is hypoglycemic, you do your counter-regulatory hormones, and you look at your ketones, and you do some form of investigation for other causes of inborn errors of metabolism, like, other causes of hypoglycemia, like inborn errors of metabolism. So that's what we call a critical sample. It's the level of the glucose, your counter-regulatory hormone, you do your blood gases, you do your ketone levels to send to the lab in trying to investigate what is the cause of this persistent hypoglycemia. So that concludes our topic for today. I know it's a bit longer, but neonatal hypoglycemia is a longer topic. I actually tried to summarize it to at least 30 minutes.